CMG26C. Other obstetric and gynecological emergencies. Antepartum hemorrhage, APH. Antepartum hemorrhage is defined as any bleed from the genital tract after the 20th week of pregnancy, occurring before labor. It is a complication that affects 2 to 5% of pregnancies. APH may or may not be associated with accompanying contractions. The bleed can be concealed internally, fully or partially, and this may present with severe abdominal or pelvic pain, with a tense, tender uterus and signs of shock. Causes of APH include placenta previa, placental abruption, trauma, genital infections, vasa previa, etc. Check the mother's antenatal card, if available. Treatment for antepartum hemorrhage. 1. Reassurance. 2. Do not palpate or massage the uterus. This may stimulate further bleeding and/or uterine activity. 3. Intravenous fluid as required, as per CMG 4. Analgesia as required. Avoid opiates if pain is thought to be associated with contractions. 5. Early transport to obstetric or emergency facility, as appropriate, with early notification. 6. Women in advanced pregnancy, 20 weeks gestation or more, are generally best treated and transported in the left lateral position. PV hemorrhage in early pregnancy. Vaginal hemorrhage from conception to 20 weeks gestation. Causes include spontaneous miscarriage, ruptured ectopic pregnancy, uterine rupture, etc. Treatment for PV hemorrhage in early pregnancy. 1. Reassurance. 2. Intravenous fluid as required, as per CMG 3. Analgesia as required. 4. Early transport, usually to emergency department, with early notification. Preeclampsia and eclampsia. Preeclampsia is a multisystem disorder of pregnancy, characterized by hypertension, systolic BP 140, or more, diastolic BP 90, or more, and involvement of one or more other organ system, and/or the fetus. Suspect preeclampsia in a pregnant, unwell patient, for example altered LOC, headache, abdominal pain, visual disturbances, with an increased blood pressure. Eclampsia is rare, and is characterized by seizures. Seizures may occur antenatally, intrapartum or postnatally, usually within 24 hours of delivery, but occasionally later. The only definitive treatment of preeclampsia and eclampsia is the birth of the baby. Treatment of preeclampsia and eclampsia. 1. Suspected preeclampsia, rapid transport to nearest appropriate facility. 2. High-flow oxygen. 3. Preeclampsia, ICP administer magnesium sulfate as per pharmacology. 4. Eclampsia. Treat seizures as per CMG 22. Noting that intravenous and intraosseous magnesium sulfate should be the first-line treatment, if possible. 5. Treat other associated conditions as per appropriate CMG. 6. Urgent transport with early notification to the emergency department, not birth suite. Women in advanced pregnancy, 20 weeks gestation or more, are generally best treated and transported in the left lateral position. Apparent antenatal fetal distress. This may be seen as decreased or absent fetal movement, presence of meconium in the liquor, etc. Note that non-specialist fetal heartbeat auscultation should not be performed, as it is not accurate and can cause further distress to the woman. Treatment for apparent antenatal fetal distress. 1. Reassurance. 2. Intravenous fluid as per CMG 3. Early, rapid transport to obstetric facility, with early notification. Women in advanced pregnancy, 20 weeks gestation, or earlier, are generally best treated and transported in the left lateral position. Postpartum hemorrhage, PPH. Postpartum hemorrhage is generally defined as an acute hemorrhage with blood loss of 500 milliliters or more, occurring within 12 weeks post-delivery. Severe PPH is defined as 1000 milliliters or more of blood loss. Causes of PPH are commonly known as the 4 T's, and management is centered around addressing these as appropriate. 1. Tone. Uterine atonia, the most common cause of PPH. 2. Trauma to the genital tract. 3. Tissue. Retained products, for example placenta or membranes. 4. Thrombin. Coagulopathy, rarely the primary cause of PPH. Blood loss is extremely difficult to estimate, and is notoriously underestimated. Assessment of severity must therefore focus on the patient's vital signs and the secondary survey. Any indication of shock up to 12 weeks following delivery must be managed as PPH. Treatment for PPH. 1. Position patient flat, and maintain body warmth. 2. High flow oxygen. 3. Intravenous fluids as per CMG14, warm fluids if possible. 4. If placenta delivered, massage fundus firmly and continuously. Uterus may relax promptly if massage is ceased. 5. If placenta in situ. As a last resort, in the event of torrential PPH with signs of hypovolemia, it is permissible to apply fundal massage with the placenta in situ. This is a last resort exception. 6. Examine genital tract for damage. Apply pressure to bleeding areas. 7. Encourage mother to empty her bladder, if possible and practical, to promote uterine contraction. 8. Encourage breastfeeding of infant, if possible and practical, to promote uterine contraction. 9. Transport without delay to the emergency department, not birth suite. Notify hospital of situation as early as possible. 10. If possible, keep all pads, towels, and swabs for volume loss assessment at hospital. Weighing these items is often the more accurate way to assess loss,